How's it going, guys? We have a hyperpass level question for MSK Step 1 Internal Medicine 2CK. Just need to check off the box on answers that show up on the USMLE extremely high yield, even if this question's too easy for some of you guys, all right? So 54-year-old woman, 1-month history, worsening pedal edema, 6-month history, back pain, MCV 108, serum calcium 10.4, normal range 8.4 to 10.2. And then this x-ray here, identical to one on one of the NBME exams, okay? So our pastoral and the question wants to know next specific diagnosis. So our diagnosis is multiple myeloma. All right, multiple myeloma is a cancer of plasma cells, and plasma cells mature from B cells. Plasma cells secrete immunoglobulins, okay? So immunoglobulins are proteins. Now, proteins flying around and depositing where they shouldn't be depositing can cause amyloidosis. That's what amyloidosis is, which is why we have pedal edema. It's nephrotic syndrome. Okay, so you need to know multiple myeloma is the highest yield cause of renal and cardiac amyloidoses. Renal is nephrotic syndrome, apple green birefringence, Congo red stain. Cardiac's going to be diastolic dysfunction with an S4 heart sound. I've talked about this stuff in my high-yield cardio PDF as well with images. They want you to know the image of the myocardium with amyloidosis multiple myeloma. So history of back pain, it's mid to upper back pain, very buzzy and easy. You say, what's going on with the MCV, normal range 80 to 100? You can get increased MCV in multiple myeloma. And I've seen literally an MCV of 108 on one of the NBME exams for it. Okay, so just impaired DNA synthesis, that's what can cause the MCV to increase. The RBCs spend longer than they normally do, maturing in the bone marrow, okay? And they can end up larger, but less effective in terms of their ability to carry oxygen. So serum calcium 10.4. So this is because we have lytic lesions of bone, right? So pepper pot skull, ribs, and also the humerus here. Now it's a slightly unusual x-ray because, as I just fucking said, the pepper pot skull and the ribs, those are actually the textbook buzzy locations for lytic lesions. But the humerus, it's on one of the NBME exams, okay? So next best step in diagnosis, we're going to do serum protein electrophoresis, which is going to detect our IgG kappa lambda M protein spike, okay? That's what we call it, monoclonal protein spike, but it's immunoglobulin light chains, okay? IgG kappa lambda light chains, and those are proteins. And as I already talked about, those are flying around, depositing in tissues. They also stick to RBCs. So RBCs, the fact that they're more sticky, adhere to each other, that can cause rouleau formation with a high ESR. So serum protein electrophoresis, this answer, even if it's too easy for some of you guys, this is all over the NBME exams, okay? So I have to check the box on it. And then after serum protein electrophoresis shows us our IgG kappa lambda spike, we can go on to do bone marrow biopsy for confirmation. It's what USMLE wants, that sequence, okay, where we look for greater than 10% plasma cells on bone marrow biopsy. Under 10% is MGUS, monoclonal gammopathy of undetermined significance. Patients tend to be asymptomatic when the plasma cells are under 10% anyway. On the cusp, 10%, we call it smoldering myeloma. USMLE won't test that diagnosis, but over 10%, you need to know that that's what we see for multiple myeloma. Now, some of you are going to be very confused, pedantic right now. You say, Mike, I don't get it. Why is blood smear wrong? Because by all means, I've harped on this in prior YouTube clips. I've talked about it in my Qbank PDF, where you can get clock face chromatin. That's the colloquialism when we look at plasma cells on a blood smear. Okay, the clock face chromatin is how they describe it. So you say, well, isn't that part of the diagnosis? I agree with you, okay? But and what about urinalysis, looking for Bence-Jones proteinuria? Wouldn't we do that as part of the workup? I agree with you as well, but it's fucking wrong for USMLE. In other words, I have never seen NBME material assess specifically blood smear or urinalysis as part of the sequential workup for multiple myeloma. I would say when they ask you for next best step in management for 2CK, my guess would be 3 out of 4 questions are just straight up serum protein electrophoresis, hyper/ultra buzzy and pass level, and then 1 out of 4 they say which of the following is most likely to confirm the diagnosis, and it's just straight up bone marrow biopsy, okay? But I haven't seen them play games as far as OMG after the serum protein electrophoresis. Are we going to do a urinalysis looking for Bence-Jones proteinuria? Are we going to do a blood smear looking for clock face chromatin plasma cells? I haven't seen them do that, okay? But they can mention those findings in the vignette. That's obviously important, you know that. Flow cytometry, wrong fucking answer, unrelated, just buzzy distractor. Some students don't know what it is. It's just a modality, a lab technique, modality that can be used to diagnose characteristics or ascertain characteristics of certain cells. For example, Langerhans cell histiocytosis, made a clip on that the other day. You can use that to detect CD1A positive Langerhans cells, right, with the Burbeck granules. But to detect the CD1A, you can do flow cytometry. I haven't really seen this assessed as an answer on USMLE for pretty much anything. Flow cytometry, wrong fucking answer. You know the deal. To make more content, if you like my stuff, subscribe channel. Appreciate your time. That's it.